Welcome back to the Deep Dive, where we take a stack of source materials and, well, we pull out the essential insights just for you.
Think of it as your shortcut, your fast track to being well-informed on a specific topic. We do the digging.
Exactly. And today we're plunging into something pretty complex from veterinary medicine, Pancytopenia in dogs and cats.
Yeah, we've got some pretty detailed material here, excerpts from a clinical text on veterinary internal medicine, so quite specific.
And our mission, as always, is to unpack what this thing, Pancytopenia, actually is, what causes it, how you'd recognize it, and what can be done about it using only the information in these texts.
Right. And it's important to note the material says it's uncommon, but, it can be really serious when it does happen.
So this is your shortcut to understanding it. Let's get started.
Let's do it.
Okay, let's start right at the beginning. This word, Pancytopenia, what exactly does it mean?
Okay, so first off, the source material is really clear. Pancytopenia isn't a disease in and of itself.
Not a disease.
No. It's defined as a group of laboratory findings that are all happening at the same time. A pattern, really.
And what are those specific findings? What makes up the pattern?
It's the combination of three things being low in the blood count simultaneously. First, leukopenia, that's low white blood cells. Second, non-regenerative anemia, so low red blood cells, specifically where the bone marrow isn't kicking out new ones fast enough.
Right, not regenerating.
Exactly. And third, thrombocytopenia, which is low platelets. So low whites, low reds, low platelets all at once.
Got it. So it's like a snapshot of the blood showing deficiencies across the board. A signal that something deeper is wrong.
Precisely. It points towards an underlying problem, often with the bone marrow or how the body is handling blood cells.
Which leads us perfectly to the next question. How does this state actually happen?
Right. If it's not the disease, how do you get there?
Yeah, how does a dog or cat end up with all three of those cell lines running low at the same time? What are the, fundamental ways this occurs?
Well, the material we reviewed outlines the main mechanisms. The big one is decreased production in the bone marrow.
The factory isn't working right.
Pretty much. This happens when the stem cells, the basic cells that are supposed to grow into all the different blood cells, when they get damaged or suppressed, or maybe they just can't mature properly.
And I remember reading it matters which stem cells are affected.
Absolutely crucial. If the problem hits the pluripotent stem cells, those really early ones that can become any type of blood cell, then you get pancytopenia, because all the production lines are affected downstream.
Okay.
But if it only affects the committed stem cells, the ones already destined to become, say, just white cells or just red cells, then you typically only see a drop in that specific cell type, not all three.
Okay, so hitting the problem right at the source, the main stem cells, is one major route to pancytopenia.
Definitely a key mechanism. Now, the other main way this happens involves things going on outside the bone marrow.
Like what?
This is described as increased peripheral use, destruction, or sequestration of the cells.
So basically, these cells are being used up, chewed up, or maybe trapped somewhere faster than the marrow can replace them.
That's the idea. And here's a really interesting point the source makes. If cells are being used or destroyed rapidly, the bone marrow should notice and try to compensate, right? It should ramp up production.
Makes sense.
But that response isn't instant. The text says it takes about 2 to 3 days just to start seeing an increase in cell counts and maybe a week to reach peak output.
Ah, okay. So early in the process, you wouldn't need such a massive rate of loss to cause low counts compared to later, when the marrow should theoretically be churning out more cells.
Exactly. The rate of destruction needed to keep counts low is actually lower in the first few days than it is a week or two later.
That's a neat detail. And what about sequestration? You mentioned cells getting trapped.
Yeah, sequestration is where cells essentially get stuck in tiny blood vessels, especially in organs like the spleen, the intestine, or even the lungs. So they're removed from circulation, leading to low counts in the blood sample, even if they are being produced okay.
Okay, so summarizing the how. Either the factory itself, the bone marrow, is broken or suppressed, or the finished products, the cells, are being lost, destroyed, or trapped faster than the factory can keep up, especially in that initial period before production ramps up.
That really captures the two core mechanisms described in the material.
Now, given this is all about blood cells, it obviously impacts the hemic, lymphatic, and immune systems. But where specifically, which organs does the source say this condition shows up?
Well, primarily the bone marrow itself, naturally, since that's the production site.
Right.
But also other organs heavily involved with blood cells, the spleen, which filters blood, lymph nodes, part of the immune system, and other lymphocytic tissues.
And what happens in those organs?
Depending on the underlying cause, the source says these organs can show various changes, things like cellular depletion, degeneration, actual tissue death or necrosis, or even abnormal growth patterns like hyperplasia, dysplasia, or dyscrasia. So a range of effects.
So the impact isn't just a number on a lab report. It can be physical changes in these key tissues, too.
Correct. It reflects the underlying disease process.
Let's talk prevalence. How often does this actually happen? Is Pancytopenia something vets see all the time?
According to the text we reviewed, it's actually considered an uncommon occurrence. Which is interesting, right? Even if the underlying causes are present, it doesn't always progress to full pancytopenia.
Uncommon. Was there a specific number mentioned?
Yes, they cited one study, Weiss et al., from 1999, which found an incidence of about 2.4% in dogs looked at in that particular study. So yeah, relatively rare.
Okay, 2.4% in that dog study. So uncommon. Does where you live matter? Geography.
Not for pancytopenia itself, no, unless the specific underlying cause has a geographical link. The source mentions things like leishmaniasis or histoplasmosis, which are infections more common in certain parts of the world.
Right, the cause might be localized, but the condition itself isn't.
Yeah.
What about the patient? Any particular age, sex, or breed more likely to get this?
The material indicates no specific signalement, no particular age, sex, or breed seems predisposed, so theoretically it could affect any dog or cat.
So uncommon, not tied to location unless the cause is, and could potentially affect any pet. That's good context. Now, let's shift to what you might actually see. If a pet has Pancytopenia, what signs would an owner notice, or what would a vet find? What are the clinical signs listed?
Right, the signs link directly back to which cell lines are low. The history an owner gives might reflect the underlying cause, but the signs specifically tied to the pancytopenia itself are things like, well, lethargy or maybe seeming pale.
Okay, tiredness, paleness. That's from the anemia, right? Low red cells.
Exactly, lack of oxygen delivery. Then you might see signs of bleeding.
Bleeding. Like what?
Petechial hemorrhage, those tiny little pinpoint bruises you might see on the gums or skin. Or more obvious bleeding from mucous membranes. That's from the thrombocytopenia, the low platelets needed for clotting.
And the third cell line, the white cells.
Low white cells, the leukopenia, means the immune system is weak. So the source mentions signs like repeated fevers or infections that are hard to clear up or just keep coming back, frequent or persistent infections.
Okay, so signs related to poor oxygen, poor clotting, and poor infection fighting. Makes sense. What about on a physical exam by the vet?
Pretty much confirms those things. Lethargy, weakness, definitely pale mucous membranes. Checking the gums is key. You might see those petechiae, the pinpoint bruises.
Huh.
And that mucosal hemorrhage could be more significant. The text gives examples like blood in the urine hematuria or nosebleeds, which is epistaxis, even coughing up blood, hemoptysis, or finding melena, that dark, tarry stool from digested blood.
Wow, some serious signs there.
Definitely. And of course, a fever might be present if there's an underlying infection kicking things off.
That paints a pretty clear and, frankly, worrying picture. Okay, now for the really big question, the causes. You said this is where it gets complex, and the list in our material is, well, huge.
This is probably the most critical takeaway. Pancytopenia isn't one thing. It's a common endpoint for many, many different problems that mess with blood cell production or survival. The causes fall into several big categories.
Okay, let's walk through them. First up, infectious diseases or agents.
Right, infections are a major player. The source lists quite a few. Viral ones like feline leukemia virus, FLLV, feline immunodeficiency virus, FIV, feline infectious peritonitis, FIP, infectious canine hepatitis, ICH, and both canine and feline parvovirus.
Okay, lots of viruses.
Yep. Then fungal diseases like histoplasmosis, bacterial infections like ehrlichiosis, protozoal diseases like cytozoonosis and leishmaniasis, and even just overwhelming systemic inflammation like endotoxemia or septicemia. So a really wide range of infectious triggers.
There's a lot just for infections. What's the next category? Drugs, chemicals, and toxins. This one seems really important because it includes things pets might encounter more routinely.
Absolutely. And the list here is eye-opening. Specific medications are cited.
Yeah.
The antibiotic chloramphenicol, certain types of cephalosporins and sulfa drugs like trimethoprim sulfatazine, common dewormers, believe it or not, like albendazole and fenbendazole, grisafulvin, and antifungal. Even some heart medications, ACE inhibitors like captopril. methimazole, used for hyperthyroidism in cats, phenobarbital for seizures, phenylbutazone, an older anti-inflammatory.
Wow. Some of those are really common drugs.
They are. It really highlights the need for awareness. The list continues with estrogen, which can be given as a medication or produced by certain tumors, like Sertoli cell tumors or interstitial cell tumors, especially in, say, cryptorchid males.
Okay.
Chemotherapy drugs are a big one, as you expect, given they target rapidly dividing cells. The source lists several: azathioprine, carboplatin, cyclophosphamide, cytosine arabinoside, doxorubicin, hydroxyurea, vinblastine.
Right. Chemo makes sense.
And finally, environmental toxins, things like fusarium T2 toxin found in moldy grains, thallium, which used to be in some rodenticides, and ionizing radiation.
That is an incredibly long and varied list just for drugs and toxins. It really drives home how sensitive the bone marrow can be to chemical interference.
It really does. Okay, next category: proliferative and infiltrative diseases. This is basically where abnormal cells take over the bone marrow space.
Like cancers?
Exactly. Hematopoietic neoplasia, so cancers of the blood-forming cells themselves, like leukemias, lymphoma, or conditions called myelodysplasia, where the cells are abnormal.
Right.
The source also lists myelofibrosis, where scar tissue replaces the marrow, myelophysis, which is sort of a general term for normal marrow being replaced by any abnormal tissue, and osteosclerosis, where the bone itself becomes denser and crowds out the marrow space.
So the marrow factory floor is getting physically crowded out or replaced by stuff that shouldn't be there.
That's a good way to put it. And the final major category listed is immune-mediated diseases.
Ah, where the body attacks itself.
Precisely. In this case, the immune system mistakenly targets the bone marrow precursor cells, the stem cells or early cells. The main example given is aplastic anemia, which the source notes is also called aplastic pancytopenia if all cell lines are affected. It can also apparently happen in some cases of immune-mediated hemolytic anemia, where red cells are attacked, or immune-mediated thrombocytopenia, where platelets are attacked, if the immune system also targets the precursor cells in the marrow, not just the mature cells in the blood.
So the body is essentially attacking the factory workers or the factory itself.
Wow. That list of causes: infections, drugs, toxins, cancers, autoimmune issues. It's incredibly diverse. No wonder diagnosis is tricky.
Exactly. And the specific risk factors naturally depend entirely on which of these potential causes is actually in play for a given patient.
So let's say you see the signs. The lab work confirms pancytopenia. How on earth do you figure out which of those many possibilities is the culprit? What's the diagnostic journey look like according to the source?
It really is detective work. One clue mentioned in the material is the onset of the signs. How quickly did things seem to go wrong?
Acute severe signs might point more towards things causing rapid destruction or sequestration of cells, whereas a slower, more gradual, insidious onset might suggest something suppressing the bone marrow over time, like a drug or a chronic condition.
Okay, so the timeline gives you a hint, and then obviously you dig deeper into the lab results.
Yes. And here's a really practical point the source makes. You have to be careful about things that can alter lab results and muddy the picture.
Like what?
Well, for example, giving glucocorticoids, steroids, can artificially raise the neutrophil count, which might hide an underlying leukopenia. Or even just a difficult blood draw could cause platelets to clump or red cells to break hemolysis, making those counts look falsely low on the machine.
Ah, so rule out technical errors first. Good point. Assuming the results are accurate, what key things confirm the pancytopenia state?
Well, the lab findings confirm the definition. You'll see leukopenia, often specifically low neutrophils, neutropenia, and maybe low lymphocytes too, lymphopenia. You'll see non-regenerative anemia. The severity depends on the cause and duration. And thrombocytopenia, low platelets.
In the blood smear, the source seemed to really emphasize looking at the blood smear.
Absolutely vital. The blood smear is where a trained eye looks directly at the cells under the microscope. It can provide huge clues.
Like finding the cause directly.
Sometimes, yes. You might actually see infectious agents hiding inside the cells the text mentions, Ehrlichia or histoplasma as examples. Or you might see abnormal-looking cells that scream cancer, suggesting those myeloproliferative or lymphoproliferative diseases.
Wow.
Or you might see changes within the white blood cells themselves, things called toxic changes. The source says these can indicate bone marrow injury, maybe from parvovirus or a drug or toxin, or they can suggest severe systemic inflammation like septicemia or endotoxemia.
So the smear gives you a direct window into potential causes or the state of the marrow. What about general blood chemistry tests?
Biochemistry results really depend on the underlying cause
Yeah.
and if other organs are involved. If the cause is also affecting the liver, you might see elevated liver enzymes. If the kidneys are involved, you might see changes there. It's very context dependent.
Okay. Any other specific tests mentioned as being particularly useful?
The reticulocyte count is highlighted as incredibly important.
That measures young red blood cells, right?
Exactly. If that count is low, even though the patient is anemic, it strongly confirms the anemia is non-regenerative. It tells you the bone marrow isn't responding properly, isn't making enough new red cells. That finding really points the finger at a primary bone marrow problem and justifies digging deeper.
Okay, so a low red count is a big flag for a marrow issue.
Definitely. And then, of course, specific tests like immunologic assays or PCR can be used to hunt for those specific infectious agents we listed earlier, like Ehrlichia, FLV, FIV, etc.
Makes sense. If you suspect the factory is the problem, eventually you need to go look inside the factory. Which brings us to the bone marrow examination.
Yes, if the blood work and other tests haven't revealed the cause, and especially if you have that non-regenerative anemia suggesting a primary marrow issue, then a bone marrow examination, either an aspirate where you draw liquid marrow or a core biopsy where you get a small solid piece, is indicated.
What might they find when they look at the marrow sample?
Well, the findings can vary, which again helps narrow down the cause. Interestingly, you might find a hypercellular marrow more cells than normal.
That seems weird if the blood counts are low.
It does, but the source says it can happen in conditions like myelodysplasia, where cells are made but are abnormal and don't get out properly. Some types of leukemia, or even during the recovery phase from something like parvovirus, where the marrow is trying really hard to rebuild.
Okay, so lots of cells isn't always good. What about the opposite, too few cells?
Right, a hypocellular marrow, too few cells, is more directly what you might expect. This points towards the marrow being suppressed, damaged, or replaced. You see this with marrow necrosis, tissue death, myelofibrosis, scarring, or suppression from causes like drugs, estrogen toxicity, or that immune-mediated aplastic anemia.
And what if you can't even get a liquid sample, an aspirate?
The material notes that if you try to get an aspirate and can't draw much out, a dry tap, it strongly suggests conditions like myelofibrosis, severe necrosis, or just marked hypocellularity. In those cases, the core biopsy becomes essential because it gives you the actual tissue structure to look at.
And the core biopsy really shows what's going on structurally.
Exactly. It lets the pathologist see what's replacing the normal blood-forming tissue. Is it dead tissue? Is it cancer cells? Is it fibrous scar tissue? Or is it mostly just fat replacing the active marrow? It directly helps pinpoint the underlying pathological process.
That whole diagnostic process is quite the investigation. Okay, so let's say you've done all that detective work. You've hopefully identified the underlying cause. What happens next? What does the source material say about treatment and management?
The approach to treatment described has two main arms. First, there's supportive treatment. This is all about managing the immediate, potentially life-threatening consequences of having those low cell counts.
Okay, like dealing with the symptoms.
Essentially, yes, managing the risks. This includes things like aggressive antibiotic therapy because the low white cells mean a high risk of infection turning into sepsis, and blood component transfusions are often critical.
Right, giving back what's missing.
Exactly. Packed red blood cells if the anemia is severe to help with oxygen delivery. Platelet transfusions if there's active bleeding or the platelet count is dangerously low.
Okay, so support the patient through the crisis. What's the second arm of treatment?
The second, and arguably most crucial arm, is treating the underlying condition. The source material really hammers this point home. It's paramount. You absolutely have to identify and address the root cause.
Makes total sense.
Whether that means treating the specific infection, stopping the offending drug or toxin exposure, starting chemotherapy for cancer, or using immunosuppressive drugs for an immune-mediated cause, you have to fix the primary problem. Otherwise, supportive care is just, well, temporary support.
Right, you're just patching leaks if you don't fix the faulty plumbing. Are there specific medications listed, or is it all just treat the cause?
It's mostly about treating the specific diagnosed cause. The overall treatment plan is highly tailored based on that diagnosis and also on how severe the cytopenias, the low counts actually are. It's definitely not a cookbook approach.
Understood. Now, very importantly, other things you should absolutely avoid doing. Any contraindications mentioned?
Yes, and this is critical for safety. First, you have to avoid any drugs that could potentially suppress the bone marrow further. Remember that long list of drugs that can cause pancytopenia. You certainly don't want to give any of those or anything similar to a patient whose marrow is already struggling.
Good point. Don't make it worse.
Exactly. And second, avoid drugs that interfere with platelet function. The source specifically mentions NSAIDs, nonsteroidal anti-inflammatory drugs, and clopidogrel, a common antiplatelet drug. Since the patient already has low platelets and is at risk of bleeding, you don't want to impair the function of the few platelets they have left.
That makes perfect sense. What about precautions? Anything to be particularly careful about?
The main precaution highlighted relates to using immunosuppressive drugs like glucocorticoids, steroids. While these might be necessary to treat an underlying immune-mediated cause, you have to remember the patient is already immunocompromised because of their low white blood cell count, leukopenia. So the source stresses that using steroids or other immunosuppressants requires extreme care and very frequent monitoring. You're walking a tightrope between treating the cause and potentially increasing the risk of overwhelming infection.
Wow, yeah, that sounds like a really tricky balancing act. Are there any alternative drugs mentioned that might help boost cell production?
Yes, the material does mention recombinant hematopoietic growth factors. These are basically manufactured versions of the body's own signaling molecules that tell the bone marrow to make specific types of cells.
Like kickstarting the factory?
Kinda, yeah. Examples given are RHG-CSF, recombinant human granulocyte colony stimulating factor, to help stimulate neutrophil production, those key infection-fighting white cells, and re-EPO, recombinant human erythropoietin, to stimulate red blood cell production for anemia.
Interesting. So options to try and directly stimulate recovery.
Potentially, yes, depending on the situation and availability.
Okay, so treatment is underway, focusing on the cause plus support. What about the longer-term view? Follow-up, monitoring, maybe prevention, and ultimately the prognosis.
Monitoring needs to be really intensive, especially initially. The source recommends daily physical exams, keeping a close eye on body temperature because fever is a key sign of infection. And periodic CBC's complete blood counts are essential to track how the cell counts are responding to treatment.
How often do they need blood counts checked?
It depends. The source says the frequency depends on the severity of the pancytopenia, the patient's age and overall condition, and again, the underlying cause, and how quickly you expect things might change. It could be daily initially in critical cases, then spaced out.
Okay, intensive monitoring. Is there anything that can be done to prevent pancytopenia in the first place?
Well, given the wide range of causes, you can't prevent everything. But the material lists a few possibilities tied to specific causes. For instance, castration of cryptorchid males, those with undescended testicles, is recommended because those retained testicles are prone to developing Sertoli cell tumors, which can produce estrogen and cause marrow suppression.
Ah, okay, preventing one specific cause.
Right. Vaccination against relevant infectious diseases is another preventative measure mentioned. Think parvovirus, FAV. And for pets undergoing cancer treatment, frequent CBC monitoring during chemotherapy or radiation therapy can help catch drug-induced marrow suppression early, hopefully before it becomes severe pancytopenia.
Those make sense, targeting known risks. What are the biggest dangers or complications to worry about during pancytopenia?
The two major complications highlighted are hemorrhage, due to the severely low platelets, and sepsis, overwhelming systemic infection due to the lack of white blood cells to fight bacteria or other pathogens. These are the things that can quickly become life-threatening.
Hemorrhage and sepsis, got it. And finally, the bottom line. What's the expected course and prognosis for a pet diagnosed with this?
The source material is very clear on this. The prognosis depends entirely, 100%, on the underlying cause. Because the potential causes range from treatable infections to aggressive cancers or irreversible marrow failure, the outcome varies hugely. As a result, the text concludes that a guarded prognosis is often warranted, meaning the outcome is uncertain and potentially poor.
Wow. So starting from just 3 low numbers on a blood test, we've gone through this incredibly complex web of causes, diagnostics, and treatments.
Yeah, it really illustrates how pancytopenia isn't the end of the story. It's the beginning of an investigation. We saw how it can be triggered by infections, common medications, toxins, cancers, the immune system, just a huge range of possibilities.
This deep dive really hammered home to me that seemingly simple lab results can mask incredible complexity underneath. It demands that careful, methodical detective work to uncover the root cause, and the treatment has to follow that fix the why, don't just treat the what.
Absolutely. That principle is key. And it showcases the amazing, intricate balance of the blood and immune systems in our pets, and why vets need such a broad knowledge base when tackling these bone marrow-related issues.
So what does this all mean for you listening? And I think it highlights just how interconnected things are inside the body and how many different factors from infections to medications you might have at home can potentially impact something as fundamental as blood cell production.
Which does make you wonder, given this huge diversity of causes we've discussed, common drugs, specific infections linked maybe to lifestyle or geography, risks associated with being unneutered, vaccination status, how might a better, broader understanding of all these potential risk factors influence how we approach preventative care? Or maybe how often we recommend routine screening blood work, even for pets that seem perfectly healthy on the outside? Something to think about, definitely.